All right, let's dive right in. Today, we are putting on our detective hats and stepping into the world of medical investigation. We're tackling one of the most baffling challenges a doctor can face, a fever that just refuses to go away, with a cause that's absolutely nowhere in sight. This is the story of pyrexia of unknown origin.
So just imagine this for a second. You've got a fever, and it's not going away. Days turn into weeks, and despite every test, every doctor, nobody can figure out why. This isn't just some stubborn bug. It's a full-blown medical mystery that kicks off a pretty intensive investigation.
So at what point does a simple, persistent fever get this official, serious-sounding title, Pyrexia of unknown origin, or POU for short? Well, there's actually a very strict set of clinical rules that doctors use to make that call.
Okay, so there are 3 ironclad rules. First, the fever's got to be significant. We're talking over 101 degrees Fahrenheit. Second, it has to stick around for at least 3 full weeks. And the third rule, this is the real kicker, a diagnosis still hasn't been found after 1 whole week of intensive investigation inside a hospital. So this has already stumped the first wave of serious medical detective work.
So once a case officially gets that PUO label, the investigation really opens up. Doctors start pulling together a lineup of potential culprits, and it's a wide range of the usual and sometimes very, very unusual suspects.
This chart breaks it down perfectly. Look at that huge slice at the top, infections. They're the #1 culprit, accounting for a massive 40% of cases. Then we have a tie for second place between neoplasms, which are cancers, and collagen vascular diseases. They each take up about 20%. After that, you've got a miscellaneous grab bag at 10%, and then there's that last really fascinating slice. In 10% of cases, they never find the cause.
So where does the investigation start? Well, you always go after the prime suspect first, right? And that means infections. Since they're responsible for that big 40% chunk, it's just the most logical place to begin. The tricky part is, these usually aren't your common run-of-the-mill germs.
Yeah, we're talking about a whole host of troublemakers here. It could be something bacterial, like tuberculosis, which is famous for hiding out, or a deep internal abscess. It could be a virus, like HIV or cytomegalovirus. It could even be a parasite, like malaria. The sheer variety here is exactly why it's so hard to pin down the bad guy. Now for our second major category of suspects, neoplasms, or cancers. This is so important because sometimes the only initial sign that something is seriously wrong, the only symptom of a cancer, is a stubborn, unexplained fever. It's the body's way of reacting to those malignant cells.
The types of cancer most often tied to PUO tend to be the ones involving our blood and immune systems. So, we're looking at things like lymphoma, Hodgkin's disease, and leukemia. These conditions can create a body-wide inflammatory response, and that's what shows up as that relentless fever.
Okay, our third major category is a bit of a plot twist. With collagen vascular diseases, the body is basically attacking itself. These are autoimmune disorders where your own immune system gets confused and causes widespread inflammation. The result, you guessed it, a constant fever.
Some of the main culprits in this group are conditions like juvenile rheumatoid arthritis and lupus. In these situations, the fever isn't from an outside invader like a bacteria or virus. It's actually caused by the body's own defense system going completely haywire.
So, with such a massive list of suspects, how in the world do doctors start to narrow things down? Well, the most critical work begins right at the crime scene with the patient. The patient's own story is almost always where the most valuable clues are hiding.
This is just fundamental detective work, right? The investigators, the doctors, they ask about everything. Where have you traveled recently? That could point to an exotic infection. What medications are you on? Because some drugs can cause a drug fever. Have you been around anyone who's been sick? Every single detail matters.
Next up is the physical exam, which is like searching the scene for hard evidence. Are there any strange skin lesions? Are the lymph nodes swollen? That's a classic sign of either an infection or something like lymphoma. Can they feel a mass in the abdomen, or is the liver or spleen enlarged? These physical signs can be the first real solid leads in the case. And some of the clues can be incredibly specific and honestly just fascinating. For instance, something as simple as noticing that a patient isn't sweating, even with a high fever, can be a massive breakthrough. It can point to a very rare genetic condition that affects sweat glands. It's a perfect example of how one tiny detail can crack a huge puzzle wide open.
Here's another great one.
If a doctor presses on a bone and the patient flinches in pain, that immediately helps narrow the search. That tenderness could mean osteomyelitis, which is a bone infection, or it could point to a cancer that has spread to the bone. Every clue helps to cross a few more suspects off that very long list.
So, after gathering all the clues from the patient's story and the physical exam, the investigation moves to the lab. You could think of this as the forensics phase, where samples and images are analyzed to either prove or disprove the leading theories.
And the lab has a pretty extensive toolkit. It starts with the basics, like blood counts and cultures, but it can quickly get much more specialized. A chest X-ray might show signs of TB. A bone marrow examination can spot leukemia, and a lymph node biopsy can give a definitive diagnosis for lymphoma. This is where a hunch turns into a diagnosis.
So what happens once the case is finally cracked? And for that matter, what happens if it isn't? The final stage of this whole process is all about treatment and figuring out what the future looks like for the patient.
The treatment strategy is really methodical. The main goal isn't just to make the fever go away with fever reducers. That's just treating a symptom. The real goal is to find and treat the root cause. And you'll notice they're very cautious with antibiotics. You only use those if you have a really strong suspicion it's a bacterial infection because you don't want to muddy the waters. The #1 goal is specific, targeted treatment.
Now, this is a really sobering number, because the causes of PUO are often very serious things like hidden infections or cancers. The mortality rate can be as high as 20 to 40%. It really underscores why this investigation is taken so seriously and done so urgently.
But, and this is a really big but, despite those serious numbers, there's one final fascinating twist to this whole medical mystery. In a pretty significant number of cases, the fever just goes away on its own. The patient gets better, and the doctors are left with a cold case file. Maybe it was a weird virus our tests just couldn't pick up, or some inflammatory reaction that just burned itself out. Sometimes, it seems, the body solves its own mysteries.
And that leaves us with a really profound question, doesn't it? These unsolved cases, they're not failures. They're a humbling reminder of just how complex the human body is and how incredible its ability to heal can be, often in ways we don't fully understand. So what can we learn from the mysteries that solve themselves? Maybe it's that the greatest frontier in medicine isn't just about finding all the right answers, but also about learning to respect the profound questions that we can't yet solve.